السلام عليكم، مساء الخير جميعا. سامعيني؟
وعليكم السلام. نعم أستاذ سامعينك.
اوكي، انا سويت ميوت للجميع.
وعليكم السلام والرحمة. سامعك دكتور.
وعليكم السلام. انا سويت ميوت للجميع، اللي بده يحكي بيسوي لحاله اني ميوت. يا الله، بسم الله.
وعليكم السلام. تمام دكتور.
وعليكم السلام. Can we start? Okay, I think we
إن
can.
شاء الله.
إن شاء الله. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. This is our first case. اوكي، مين بده يتبرع؟ مين بده يتبرع؟ our first case. Any volunteer? Any volunteer? بشار اليوم ماله مش مخبي حاله شكله. Any volunteer?
يعطيك العافية حكيم. أنا كنت أضبط الصوت.
الصوت واضح عندك؟
يعني ما فيه تقطيع شوي.
عندي ولا من عندك؟
لا ما بعرف إذا صوتي مليح عندكم، بس أنا الصوت اللي بوصلني فيه تقطيع شوي.
في تقطيع شوية. طيب يلا, you can start with this case.
Okay, this is selected cut axial CT scan of the cervical spine and with the bone window. Okay, it shows a bifid foramen transversarium and the bifid transverse process.
Bifid or duplicated? It is better to say duplicated, huh?
Duplicated, okay.
Okay. Duplicated foramen
transversarium.
Okay. Okay. This CT scan at what level? Which level here?
The level of the thyroid cartilage, below the cartilage, just below the thyroid cartilage.
Below the thyroid cartilage or above the thyroid cartilage?
Above, maybe above.
Here, what is this here? Anyone help? Anyone help him? Which level here? Thyroid or hyoid bone?
hyoid bone.
Hyoid.
Okay. Okay. Is this duplicated foramen, transversarium foramen, can be associated with other anomalies?
Like fusion anomalies or block vertebrae maybe.
كل واحد الله يخليكم واحد يسكر الفيديو تاعه بالله عليكم.
Fusion and segmentation anomalies maybe. Like hemivertebrae or block vertebrae maybe.
Usually these are associated with fenestration of which artery?
Vertebral artery.
Vertebral artery. So it is associated, mostly associated either with fenestration or duplicated vertebral artery. Okay?
Mhm. Okay.
Okay. Okay. Any other anomalies associated here? Compare the jugular veins together. This jugular vein on the right side, looks abnormal. Okay? Can be a normal variant. Okay. So this is a normal variant, duplication of the foramen transverse area, and it is anatomical variant, can be associated with duplication of the vertebral arteries or fenestration of vertebral artery. Okay, any question on this? Okay, let us go to the second case. Second case, who want to see the second case? Anyone to see the second case? Anyone? Anyone to see the second case? ما حدا؟ Any volunteer? Any volunteer to see the second case?
smooth interlobular septal thickening.
اوصفيها الله يخليكي. اوصفي selected cut CT scan at which level and what you are finding, differential diagnosis and most likely diagnosis. What you see? What you see? Hello, سامعني؟ سامعيني؟ What you see?
Interlobular septal thickening.
Okay, بس اوصفيها. This is selected cut CT scan at what level and describe the finding, differential diagnosis, and what's most likely diagnosis. It is selected cut CT scan at what level? At what level this CT scan? At the level of the
heart.
lower lobe, at the level of the lower lobes, and part of the heart it is there. Okay, and you see it is septal thickening involving the which part of the lung?
middle and lower zones.
Okay, it is involving the, in more anatomical, it is involving the secondary pulmonary lobules. Okay, these are the, this is the secondary pulmonary lobule. This is the secondary pulmonary lobule. And this is the secondary pulmonary lobule. This is the secondary pulmonary lobule. And these are secondary pulmonary lobule. Okay? And this septal thickening, it is smooth or irregular. It is smooth or irregular.
Smooth, doctor.
It is smooth. Okay, most of them are smooth. Some are irregular, but in the high resolution CT scan, if we see the predominant finding is smooth, we call it smooth. If it is predominantly it is not smooth, we call it irregular or nodular. Okay. So it is involving the secondary pulmonary nodule, okay, and smooth in outline. And you see here the dot here. This is the dot here. This is the central arteriole, and this is the also Y shape or inverted Y shape. It is the central arteriole. It is branching. So this is what are the differential diagnosis of smooth septal thickening?
Pulmonary edema.
Pulmonary edema, very good.
Lymphangitis carcinomatosis.
Lymphangitis carcinomatosis and
ممكن LIP.
lymphocytic interstitial pneumonia.
Lymphoproliferative disease, okay, and amyloidosis. It is rare, okay. These are the common causes of the central smooth thickening of the secondary pulmonary lobule, okay. These are the thickening can be acute, can be chronic, huh? Can be acute, can be chronic.
Yes, doctor.
Yes, can be acute, can be chronic, yes. Okay. طيب. Okay, we have here next to it, we have a question here. نشوف إذا بيشتغل معنا the question ولا ما بيشتغل. Okay. Okay, بيشتغل إن شاء الله. Which statement is false regarding the secondary pulmonary lobule? This is, we have 5 statements. The first one, it is secondary pulmonary lobule is the smallest basic anatomic unit of pulmonary structure and function. Each secondary pulmonary lobule is between 2.5 and 4 centimeter. The third one, generally 12 or fewer acini are seen in the secondary pulmonary lobule. The acinus is the basic unit of gas exchange containing several generations of branching respiratory bronchiole, alveolar ducts, and alveoli. And the term of secondary pulmonary lobule and primary pulmonary lobule and pulmonary lobule are the same. في عندكم شيء صمت بتحطوا الإشارة على الجواب الصحيح، أوكي، وصمت الإجابة، أوكي، الله يخليكم نشوف، أوكي. أوكي. ماشي. مين الجواب which statement is false؟ الأولانية secondary pulmonary lobule أو الثانية أو الثالثة أو الرابعة أو الخامسة. Okay. Okay, let us end the polling and see the result. Okay. ماشي. Okay. Most of you answered the term of secondary pulmonary lobule and primary pulmonary lobule are the same. Okay. احنا عندنا السؤال what is the statement is false. يعني لو جينا للأولانية the secondary pulmonary lobule, it is the smallest anatomic basic unit in the pulmonary structure. Yes, it is. Yes, it is correct. Each pulmonary lobule, secondary pulmonary lobule, it is between 2.5 and 4 centimeter. This is the wrong answer. Why? Normally the secondary pulmonary lobule, it is between 1 and 2.5 centimeter. Okay, 1 and between 0.5 centimeter. And the rest of the answer, the rest of the statements are correct. This one, it is each secondary pulmonary lobule, it is between 2.5 and 4 centimeter. It is the wrong answer. And the rest of the statements are okay. خلينا نفرجيكم الريزلت اللي شفتوا الريزلت. Okay. You said it is 61% of the fifth answer, secondary pulmonary lobule, primary pulmonary lobule, are used the same interchangeably with each other. Okay. Okay. Okay, let us see what is the secondary pulmonary lobule. This is the secondary pulmonary lobule here. This is the normal, and we see the central arteriole. It is accompanied by central bronchiole, and this is the septa here. It is in the periphery, and the lymphatic, it is in the periphery. And these multiple acini in the secondary pulmonary lobule, about 12 acinas in each secondary pulmonary lobule, and it is a size between 1 and 2.5 centimeter. And the septi, it is here. This is the septi at the periphery, containing lymphatics, and the veins also, it is in the periphery, not in the center. In the center of the secondary pulmonary lobule, it is the arteriole and the bronchiole. Okay. And as we see here, this is the normal one, and there is septal thickening here, as you see here, smooth septal thickening, as we see in previous exam. And the most common cause of septal thickening, it is pulmonary edema, as you said. Okay. As we see here, this is the septal thickening of the secondary pulmonary lobule in patient with pulmonary edema. And the septal thickening can be irregular, can be nodular, and can be asymmetric. As in this patient, we have irregularity and nodularity of secondary pulmonary lobule associated with multiple nodules scattered in the lung, associated with also fissure thickening here. And the differential diagnosis of this nodular one, the most common here, we have the sarcoidosis, lymphangitis carcinomatosa, and lymphoproliferative disease. And in a smooth one, we have the pulmonary edema and can be also lymphangitis, carcinomatosa, and other rare causes. So this is the anatomy of the secondary pulmonary lobule. It is the, as we said here, it is the smallest basic anatomic unit of pulmonary structure and function. It is about 1 to 2.5 centimeter in diameter, containing 12 acini, and the acinus, it is the basic exchange, gas exchange, and also the secondary pulmonary lobule has central arteriole and the bronchiole, and in the periphery we have the veins. Okay? And septal thickening can be smooth and can be nodular. Any question on the secondary pulmonary lobule? Any question? Any question?
تمام حكيم.
Tamam. Okay, we move to the second case. Okay, what we see in the second case? What we see in the second case, في واحد رافع ايده نشوف نور اذا بتجاوب. شكرا سكرت لي. مين بده يجاوب؟ anyone?
nodular,
Okay, anyone? Okay, start. Oh, describe the finding. What is the procedure first? Describe the finding. What are the differential diagnoses? And what is most likely diagnosis, okay? What is the procedure? What is the procedure?
This is CT scan, selected images with oral contrast, no IV contrast seen, at the level of the upper abdomen.
Okay.
We can see the smooth thickening of the stomach. This is the stomach, I think.
Okay, this is the stomach here.
Yes,
okay.
this is circumferential wall thickening of the stomach.
But it is not, wait, but it is not distended. We can call it,
yes.
Okay, we can accept how many centimeter if it is not distended, the stomach wall?
Up to 3 centimeter, it's accepted.
Yeah, it is about 1.5 centimeter can be accepted
Yes.
as a normal. And looks like normal. And you said there is contrast, oral contrast. There is any oral contrast in this patient?
No, because if there is oral contrast, we can see it in the stomach.
Okay, there is no oral contrast. Then this is no contrast study CT scan. What do you see in this selected cut of upper abdomen CT scan?
In the left side, at the anatomical site of the spleen, I see calcified lesion, or the
spleen.
He said, okay, خلوها تحكي. Okay.
This is the calcific spleen, calcified spleen, because it's at the anatomical site of the spleen.
Okay, this is the spleen. It is high density spleen. Okay.
Yes.
It is calcified. Okay, mash. Okay.
Yes.
What else you see?
There is the liver appears unremarkable, and
liver appear unremarkable.
And there is no gross abnormality seen in the bone, and so we can. The main pathology is the calcific spleen.
Okay, high density spleen. What are the differential diagnoses here?
The differential diagnosis will be sickle cell disease, TB,
TB, okay.
Sickle cell.
Sickle cell. Other differential.
Could be the rest of the spleen could be available if we down the cuts. If like that, maybe this is calcific lesion, like calcific cyst, or
This is the shape of the spleen. It is high density
yes,
spleen. Okay. One of the differential diagnosis حكيتي عنها sickle cell
sickle cell
disease.
disease.
Okay.
Yes, it will
وبعدين
cause the autosplenectomy because of
okay,
the.
I need to mention this is an autosplenectomy
Yes.
finding, and it is seen in sickle cell disease, which it is the homozygous or trait sickle cell.
Sorry, Doctor.
It is seen in homozygous sickle cell disease or trait sickle cell disease.
Homozygous.
Homozygous. It is seen in
Homozygous.
homozygous sickle cell disease. What are other differential
Homozygous.
Okay. What are the other differential diagnoses of autosplenectomy? حكينا sickle cell disease, homozygous. الثاني other differential diagnosis.
حكينا ممكن يكون TB، ممكن يكون other infection.
ما بتعطي TB looks like this صراحة، بتعطي نديولز أكثر منها. اوكي. بتعطي نديولز.
ممكن يكون amyloidosis أو candidiasis.
amyloidosis برضه مش a good differential diagnosis. Hemosidosis, okay. Hemochromatosis, okay. بتعطيك increased density of the spleen. And زمان كان يستعملوا contrast media يسموه
Thorathrust, yes.
Okay, this is one of the differential diagnoses. Okay, these are the differential diagnoses of a high density, high density spleen. But what are the other causes can cause the same finding other than sickle cell anemia?
You mean lesions, doctor, or calcified spleen itself?
Diseases. I mean diseases.
ممكن wandering spleen بس.
hemangioma أو lymphangioma أو
spherocytosis. Spherocytosis.
Sickle systemic lobus erythematosus can give the same appearance of
SLE.
this.
Yes.
SLE, and also a pneumococcal septicemia can give the same appearance. Okay, these are the other causes of the autosplenectomy. Okay, what is here? You see here, what is this?
Splenic infraction.
No. What is this?
Diaphragmatic folds.
Okay, what these nodules in the diaphragm, what we call it?
Spleniules.
No, this is diaphragm. This is diaphragm. This is nodule of the diaphragm, muscles of the diaphragm. What we call it? These are muscle bundles of the diaphragm, and we call it, it is a normal variant. It is scalloping of diaphragm. It is scalloping of the diaphragm, and it is a normal variant. It can be seen in good inspiration, can be seen in hyperinflated lungs, and this is muscular slips of the diaphragm. Okay, but this is a normal variant. Okay. Also, you mentioned the liver. It is okay. I think the liver, it is hypodense. It is probably high fatty infiltration of the liver. Okay. Any question of autosplenectomy? Any question? Okay, we can move to the second case. This is a tricky case, okay? tricky case. Look at it and what is the findings? What are the findings of this case? What are the findings here?
Asymmetry in the teardrop.
Those, start systematic, please. It is step by step. Describe the.
وتقطع علي قبلين مرة نشله.
Start. Okay, step by step. What is the procedure? What are the findings? And what are the differential diagnoses? And what most likely the diagnosis? Okay, try to apply to all the X-rays or CT scan or MRI we have. Try to apply to this, because in the examination you need to answer like this. Describe this is the procedure, describe the findings, and what are the differential diagnoses, what are the most likely diagnoses, and what are the most likely the diagnosis after mentioning the differential diagnosis. Okay, here as you know, this is pelvic X-ray. What is the striking feature in this pelvic X-ray here?
Erythrolytic lesion in the symphysis pubis.
Symphysis.
I will give you a hint. What are the lines in the pelvic X-ray we use to examine the pelvic X-ray? What are the lines? You know, in the pelvic X-ray, to help you to read the pelvic X-ray, what are the lines?
Iliopectineal line.
Iliopectineal line. Okay, very good. Iliopectineal line. Where's the
Shenton line?
Ilioischial spine line.
Okay. Other line?
The Shenton's line.
As we see here, this is the Shenton line. Okay. Mashi. This is the Shenton line, and this is the iliopectineal line here. Okay. And here it is, which line? This one? Posterior to the
Ilioischial.
Ilioischial line. Okay. Compare now the iliopectineal line on the right side and iliopectineal line on the left side. Here. Compare that line. خليني أشيل لك إياهم هذول. Compare the iliopectineal line on the right side and iliopectineal line on the left side.
There's irregularity. Thickening on the left side.
Very
cortical
good.
thickening.
There is thickening of the iliopectineal line on the left side. There is iliopectineal line on the left side, and this is the iliopectineal line on the left side. It is thick from here to here to here, and associated with what? Associated
Lytic
with
lesion
some,
in the sternum.
associated with some
Expansion or trabeculation, budget disease.
Okay, very good, very good, very good. So this is associated with trabeculation and trabeculation with expansion of the bone as compared from the left side, from the right side. And this is, what are the other differential diagnoses of thickening of iliopectineal line other than budget disease?
osteoarthritis.
osteoarthritis ما بتسوي لأنه بعيد الاوستيوارثرايتس. Budget disease, it is one of the differential, and it is should be once you see it, you should exclude Paget disease and other metabolic disease or metastasis and other metabolic like hypophosphatemia. Okay? This is a classic case of Paget disease involving the pelvis. It is in its early stage. It is thickening of the iliopectineal line, and you have coarse trabeculation involving the inferior pubic ramus and some acetabulum and acetabular ilium. Compare the left side with the right side. Okay, so we have here, as we see, we have lines, and these are helping us in the in reading the pelvic X-ray. And here, this is the iliopectineal line. It is evaluated, and we can see it very nicely in the pelvic X-ray, and it is evaluated the anterior column of the acetabulum, and it is seen in the pelvic X-ray in AB view, and it is linear bony bridge extended from the medial iliac wing, to what? To the medial border of iliac wing to the superior border of the pubic ramus. Okay, and ending at the pubic symphysis. Okay, from the iliac wing to the superior to the pubic ramus, superior one, and end in the pubic symphysis here. Okay, this is the iliopectineal line, and criteria for it should be smooth, continuous line, not interrupted. If it is interrupted, we look for fractures. Okay, thickening of the iliopectineal line associated, as she said, with Paget disease, familial idiopathic hyperphosphatemia, also metastasis or other metabolic diseases. Okay, this is nice case of thickening of iliopectineal line. Any question on this? Huh? Very good. Okay, this patient, daily work, بتشوفوها كتير daily work. What you see?
أحكي حكيم.
اتفضل.
This is a selected coronal cut of the chest at the level of the heart, okay, showing both lung fields. It is a PE protocol, CT scan. I can see a filling defect in the right pulmonary artery, okay, with the collapsed consolidation and air bronchogram abutting the right hemidiaphragm, which might be representing a pulmonary infarct.
Okay, في شيء تاني؟
And on the left side, there is also a filling defect with a wedge-shaped consolidation in the subpleural space, subpleural region. Most likely a saddle embolus. This is a saddle embolus.
Okay, first, this is not, it is reformatted selected image, okay? This is first, it is reformatted selected image. Here you see filling defect, okay? مظبوط?
Yeah,
in this segmental artery. What we call this sign?
The sign?
This is filling defect and surrounded by contrast. We call it bolomint sign. زي حبة الملبس. Bolomint sign, okay? And we have also here, this is branch of pulmonary artery and abrupt. And what we call this sign in this area here, big infarction here, big thrombus, sorry.
saddle embolus.
Cut-off sign.
Cut-off sign or knuckle sign, okay? Okay, and we have multiple areas of wedge shape consolidation, base at the periphery, and the apex toward the hilum. And here, this is another filling defect here also, okay? And here, another wedge shape area, apex toward the hilum, and another wedge shape area, apex toward the hilum, and another smaller one here. What and smaller, maybe smaller one here. What we call this?
Hampton hump sign.
Okay, very good. This is Hampton hump. Okay, very good. And Hampton hump, can be seen in other diseases or not? Other than pulmonary embolism and infarction? Yes, can be seen in diseases, episodic angio-invasive aspergillosis, for example, okay, and septic emboli, okay? Okay, and this is the classic appearance of اللي حكى عليها saddle shape, because the saddle shape looks like a saddle on the animal, and it is seen sometimes it is filling the right and the left pulmonary artery, okay? And here, this is the cut sign or knuckle sign, okay? This is a classic case of the pulmonary embolism with pulmonary infarction and Hampton's consolidation or Hampton's humps. Okay. Any question on this? Any question on pulmonary embolism? Okay, let us move to this. Okay, let us move to the next case. What is the next case?
Ivory vertebra.
علي صوتك لو سمحتي. What do you see? Try. Huh?
Ivory vertebra at L3.
Try to follow our steps, please, because it is important, okay? This is abdomen X-ray showing, as you said, ivory vertebra of L3, okay. Other findings? في findings ثانية؟
degenerative disc.
في degenerative disc disease changes. Okay.
Sclerotic lesion at the.
Sclerotic lesion where?
The right iliac bone at the.
Okay, very good. There is another sclerotic lesion here. Okay. If you find one sclerotic lesion or alveolar vertebra, you should try to look for another one. Okay. Can be multiple. Okay. Okay. What is ivory vertebra? This is the ivory. Okay.
Ivory vertebra.
Okay. What is that? We call it
ivory vertebra. Indicate lymphoma.
Not usually, not necessarily indicate lymphoma. Lymphoma, one of the
Osteoblastic myths.
but not necessarily indicate lymphoma. Okay?
Ivory
Is secondary due to prosthetic CA.
Homogeneous opacity of the vertebral body, not involving the. It is not involving the disc spaces. Okay, and causes. What are the causes? حكينا lymphoma.
CA prostate metastasis.
حكيتم
Metastasis CA prostate.
hemangioma, chordoma,
hemangioma, chordoma.
osteosarcoma.
يعني طيب more common أكثر من يعني
infection.
TB.
infection. Okay, infection, osteomyelitis, one of the causes. It is early stage or healing stage in the infection.
Healing.
Healing stage. Okay, Paget disease.
Tafo syndrome.
Okay, Paget disease, one of the differential also. Breast cancer in female, one of the differential also. Okay, lymphoma. حكيتوا lymphoma. Which type of lymphoma can cause ivory vertebra?
Hodgkin's lymphoma.
Or non-Hodgkin? Hodgkin. Okay, very good. And other causes, what other causes? Metastasis, حكيتوا metastasis from the prostate. Other metastasis from osteosarcoma, neuroblastoma especially, and medulloblastoma in children.
And Ewing sarcoma from the children.
And sometimes Ewing sarcoma, very good. Ewing sarcoma and carcinoma. And this is the lateral view of this patient as has ivory vertebra, as she said. Okay. ما ضلش ولا سؤال على ال. Okay, this is the حكيناه. Seen in lymphoma, especially Hodgkin, breast cancer, prostate cancer, Paget disease, osteosarcoma, carcinoma, osteomyelitis, healing stage. Okay, and this is another example of ivory vertebra from metastasis, as we see here in this vertebra, and multiple sclerotic lesion involving the sacrum and the iliac bone. Okay, it is metastasis from the breast, from the prostate here in this patient. Okay, and this is another patient from also prostate metastasis with vertebral on the CT scan. Okay. Okay. Okay, forget about the image here. Okay. Okay. What you see here, أعطيناكم الجواب in this image. Okay. What you see?
Sagittal reconstruction CT scan.
Okay, very good.
Bone window, which shows enlargement of the spinous process with degenerative changes between them. The appearance characteristic of Bastrop disease.
Okay, characteristic of Bastrop disease, and this is the Bastrop. It is from Copenhagen. He described the disease in 1933. Okay, and other name of Bastrop disease. You can know that other name of this.
Kissing spines.
Kissing spine, very good. This is another name. It is kissing spine, and it is a degenerative disease of the spinal process. Can be seen in the CT scan, even in the plain film, and in the MRI. With the MRI, you see some fluid between in the bursa between the spinal process. Okay. This is the who discovered or who described the disease. This Bastrop Christian Bassarab from Copenhagen in 1933. As you said, it is Bassarab disease or kissing the spine, degenerative disease involving the causing back pain, and in the elderly with spinal stenosis, some osteophyte formation, sclerosis, edema, and cyst formation. Very good, very good. Oh, sorry. Okay, this patient anyone, this patient? Anyone?
أحكي
تحكي يا بشار يا بشار. خلينا نشوف إذا في واحد بده تاني غيرك نشوف. ها؟
أكيد
في حدا بده غير بشار يحكي؟ ها؟ نوفل موجود ولا مش موجود؟ نوفل الكاتب. اوكي نوفل بدك تحكي يا نوفل؟ نوفل ما شكله مسكر حاله. اوكي يلا احكي يا بشار نشوف.
These are selected axial images, high resolution chest CT scan, okay, which show axial and reconstructed coronal images at the level of the heart and the superior mediastinum. The demonstration is a ground glass opacity sparing the pleura bilaterally with the interstitial septal thickening. And this is giving the appearance of crazy paving pattern.
It is dominant crazy paving. Which one is dominant? The ground glass or a crazy paving?
The ground glass.
Okay, إذا dominant ground glass, إذا you mentioned the ground glass opacities. Okay, إذا dominant crazy paving, you mentioned the crazy paving dominant. Okay.
Okay.
So here the dominant is the ground glass opacities. في صح crazy paving, but it is not dominant. Okay. So this is the ground glass opacities involving, as you said, both lungs sparing the periphery. Okay. More centrally distributed. Okay.
Yes.
Yeah, higher, more centrally distributed. Okay. What
the heart
are
is
your
not enlarged to no pleural effusion.
Okay, very good. The heart is not enlarged and there is no pleural effusion. So we exclude what?
Pulmonary edema.
We exclude cardiogenic pulmonary edema.
Cardiogenic pulmonary edema. We exclude cardiogenic pulmonary edema. What are other differential diagnoses?
Non-cardiogenic pulmonary edema. And alveolar proteinosis.
Like?
Because the mainly central predominance. So it can be
okay, alveolar proteinosis, one of the differential, yes. Okay.
Alveolar hemorrhage.
Okay. Can be anything. ما في ضغط عليها. Okay. Other differential. Alveolar hemorrhage, very good. Okay. Other differential. Infection. Okay. ARDS, infection. Okay. And infection like what? Infection like viral pneumonia or bacterial pneumonia. Okay. ماشي. Other differential.
cryptogenic organism.
Okay, كمان can be cryptogenic organizing pneumonia and also كمان ايش؟
Allergic
eosinophilic, also eosinophilic,
Hypersensitivity pneumonitis.
and hypersensitivity pneumonitis. These
Pneumonitis.
are the differential diagnosis of a ground glass appearance. Okay, this patient is a drug abuser, cocaine, and this is the manifestation of cocaine abuse toxicity in this patient. These are the differential. Okay, and this is the طبعا viral pneumonia in nowadays in the COVID or SARS in other countries or MERS, they are in the differential diagnosis. Okay, don't forget.
Excuse me, sir, but
Yes.
is the COVID-19 is subpleural, right? But this is central.
Wait. Usually it is bilateral and subpleural, but can be anything.
Yes.
Okay, can be anything.
Yes.
The typical
can be central.
The
right?
typical findings can be anything. Okay, the
Thanks
typical
a lot, sir.
is peripheral and subpleural involvement, but can be anything. No, Mafi, it is 100%, huh?
Thank you, sir. Yes, that's right. Thanks.
The ground glass appearance here, as we see from the previous slide lobule, and we have the central bronchiole, and we have the central arteriole, and as you see, the secondary pulmonary lobule, it is partially filled with material. What are the material are filled partially of the secondary pulmonary lobule? Okay, what are the materials?
Blood cells.
Fluid.
Blood cells, protein. Okay.
Protein, fluid.
Okay, these are the cells. Once it is partially filled, it is sparing the central arteriole and the bronchiole to be still visualized and not obliterating them and giving the appearance of a ground glass appearance. That ground glass appearance can be seen in the plain chest X-ray.
Sometimes.
Yeah, can be seen. Okay.
Predominantly in CT.
Yeah, but it is seen in CT. It is easily seen in CT. But in the plain film chest X-ray, it is seen, and we describe it. كتير بنسميها hazy density. مظبوط ولا لا؟ So we see it in the plain film, and we see it in the CT scan. And if the complete filling of the secondary pulmonary lobule will give us a consolidation. Okay, this is the differential between a ground glass and consolidation. Here obliterate the blood vessels, and here the blood vessels and the bronchi are not obliterated. Okay, this is, as you said, can be blood, can be pus, can be water, can be cells, and can be associated with alveolar thickening, okay, and reduced atelectasis, okay. And here, this is another secondary pulmonary lobule filled partially with some of the materials mentioned, and you see still visualizing the bronchovascular marking. And here it is also ground glass appearance, filling most of the lungs, okay, diffuse in patient with adult respiratory distress syndrome, okay. And by the way, ground glass appearance, it is non-specific. There is some hints either where is the distribution. It is centrally distributed, peripherally distributed, upper and lower distribution. Here we can limit our differential diagnosis. And the ground glass appearance, as I said, It is can be acute, can be chronic. Acute, like pulmonary edema, pneumonia, like viral infection, pneumocystis, can be in pulmonary hemorrhage and adult respiratory distress, and can be chronic in patient with organized pneumonia, bronchoalveolar carcinoma, eosinophilic pneumonia, and idiopathic interstitial pneumonia, hypersensitivity pneumonitis, and alveolar proteinosis. And these are again the differential acute and the chronic pulmonary edema, heart failure, adult respiratory, pulmonary hemorrhage, pneumonia, viral mycoplasma, pneumocystis, acute eosinophilic pneumonia, and chronic one, hypersensitivity pneumonitis, organized pneumonia, alveolar proteinosis, non-specific interstitial pneumonia, and bronchoalveolar carcinoma. And this is the here in this today we covered the abnormalities of the secondary pulmonary lobule. We covered the reticulation, and we covered the ground glass opacity. What is applicable for ground glass opacity? It is the same. Mostly it is the same differential diagnosis and finding of the also consolidation. What is left in the secondary pulmonary lobule, it is low attenuation area. Inshallah, بنشوف one of the cases, بنشوف of the differential of the low attenuation area. Okay? Okay, maybe نشوف this case. This is the last case. Okay, let us see what is you see in this last case. Okay, سهلة. It is very simple. What is this? Okay. مين بدي يتبرع؟ غير بشار. نوفل الكاتب مش رادد علينا. وينه نوفل؟ موجود نوفل؟ موجود بس شكله. اوكي، حدا بده غير نوفل؟ غير بشار؟ مين؟
أختي حكيم.
تفضلي.
Selected MRI images, axial, sagittal, and coronal cut with diffusion scan. T2,
Okay,
T1, T1 post contrast, which shows hyper intensity in both choroidic plexuses in T2, appear hypointense in T1, not enhancing, shows restricted diffusion. Picture suggestive of choroid plexus xanthogranuloma.
وين؟ اوكي طيب. طب choroid plexus it is usually non-enhancing. اوكي طيب انا بدي اعطيكي هنت. ماشي؟
Is there any leptomeningeal enhancement?
Where's the foramen manual? شايفه foramen manual؟ في إشي حوالين foramen manual؟
Right side.
ها؟
هذا septum pellucidum.
اوكي، غير السبتم pellucidum. What is this here?
Colloid cyst.
Huh?
Cystic lesion in the foramen
cystic lesion. Cystic
colloid
lesion.
cyst.
Colloid cyst.
Colloid cyst.
Okay. This is a colloid cyst, cystic lesion around the foramen minor, not causing hydrocephalus in this patient, female, with headache. Okay, not causing of the hydrocephalus, and others are normal. في شيء finding تاني لو
Thornwald cyst.
Okay, very good. This is the Thornwald cyst here. It is very good. Thornwald cyst in the nasopharynx. Okay. And
what
this
about
is
the choroid plexus, Hakim? ما في restricted diffusion?
This is the
xanthogranuloma or not?
It is xanthogranuloma, by the way. It is a normal finding,
normal yes,
variant.
yes.
Normal variant. يعني sometimes we see it, we cannot comment on it, huh?
Yes.
And it is not typical, by the way. It should be larger than this xanthogranuloma, okay?
Yes.
And this is the cyst of the CT scan. It is hyperdense. Why it is hyperdense?
Proteinaceous material.
It is proteinaceous material, okay? طيب, these are, what are the differential?
Neurocystocercosis.
Okay, neurocystocercosis. Craniopharyngioma, طبعا it is away because sometimes if it is large, can reach the foramen manual and subependyma, okay? And we can also put
subependymal giant cell tumor,
okay? Okay, we can put also giant cell tumor. These are the differential diagnosis, and this is some notes about the colloid cyst. It is benign cyst, endodermal, from forgot derivation, and the mucin containing. Once it is a mucin containing, it is platina hyperdense on CT and the proteinaceous material, and it is attached to the anterior superior third ventricle, as we see here. Okay, where it is here in this area. Okay, as we see here, anterior superior third ventricle, sometimes cause hydrocephalus. If it is caused hydrocephalus, what is the type of hydrocephalus?
Obstructive, non-communicating.
Obstructive hydrocephalus, and it is positional, okay? It is positional hydrocephalus, okay? And obstructive hydrocephalus, it is depend on how much protein, and usually it is not enhancing. And the treatment surgery, either fenestration of the cyst, aspiration, or shunting, okay? Any question on the colloid cyst? وهاي شو فيها الصورة؟
نحلة.
نحلة.
فيها نحلة، اوكي، فيها نحلة مظبوط. فيها نحلة، اوكي. Okay, any question on this? اوكي، نشوفكم ان شاء الله. ما بعرف امتى بالضبط، بجوز السبت او بجوز الاثنين، ما بعرف.